related to our culture. So maybe people prefer to ask through the chat or yeah, or write it down. So we will see.
It's my culture too. So
Yeah, because I think in Indonesia, in Malaysia now it's the sunset time, so maybe some of us have to do a pray, but maybe some are not, because I know that we have very different time region. Like now it's 7 in Philippines, also in Lombok. Now I'm in my location, but in Jakarta now it's 6. In Malaysia it's also 7, but I think not sunset time yet. So yeah.
okay.
And I don't know, Richard, you are in Ho Chi Minh?
Sorry.
Oh,
Yeah, in
yeah,
Ho Chi Minh. In Ho Chi Minh.
in Ho Chi Minh. And what time there now?
6 p.m. right now.
Oh, 6 p.m. Okay.
Good morning. Good evening.
Hello, Nick.
Hello.
Hi, Dr. Banner.
Hello.
Hi,
Hi.
thank you. Hi.
Is there a way for me to see myself while I'm speaking?
Now it's yours. It's not your slide. Now it's your picture.
Okay. All right. No. When I'm speaking, is there a way for me to see my face as well? Like
it's up to you actually.
Yeah.
Or
can I have that? Because right now I don't see anybody except my screen.
oh really?
Yeah.
Okay.
I don't know what. So
Oh, yeah,
Maybe
I think
you change the setting.
yeah, I think they changed the setting. The administrator, Dr. Silva, she's from Indonesia.
it's better that
Now
I
we miss.
yeah.
Yeah,
Now it's so I can see myself. I can see like what's going on. Because right now I'm kind of blind. I'm just looking at my slides. So I just feel like I'm myself.
Or maybe you can go back to your Zoom app.
Yeah, maybe. Okay, so let me exit now.
The Zoom and change the setting of the presentation. You can make it like the list of participant at the side or at above your screen.
Yeah, there is like a button you can say, like, you can click on show self view or turn off self view.
Oh, maybe you know what happened? Because I have to reshare my talk because yeah. All right. There you go.
Yeah. Hello, everyone. Good evening from the Southeast Asia region, and also good morning or good afternoon to all the participants that I do believe came from many different sides of the world. Thank you so much for joining us today. Today we will have a second webinar from Southeast Asia Uropathologist Organization, and this webinar will talk about the bladder and also one case that we will share together with you. Today, it's an honor for us here having Professor Glada Panner as one of our speakers. Thank you, Professor Glada Panner, for your presence. Then also we have Dr. Richard later on to share the case. And all participants, I would like to share my sincere gratitude and also thank you so much for your participation. As I informed, more than 300 people registered for this webinar. Maybe we will have all of them together during the time. And all the materials will be available through our website. Please check it out. And maybe we have also the YouTube later on that we will share on our website. Thank you so much. I would like to thank our president, Dr. Jeffrey So, and all the SEAUPS members. Thank you so much for your dedication. I really appreciate that. And we do hope that our organization is getting bigger and better day by day. And now, without further ado, I am Anglita as the Vice President, will be your moderator today. I would like to invite Professor Glada Panner as our first speaker, and his CV will be shared on our monitor. Professor Glada, please, time is yours.
Thank you, Anglita. Hello, can you hear me now?
Please. Yes.
All right. Okay. So yeah, thank you, Anglita, and good evening to everybody there in Southeast Asia. It's an honor, a big honor for me to do this presentation. And before I go to my presentation, I would like to give a big congratulations to SEAUPS. It's been magical this year, and it's pretty amazing how this organization have grown to become one of the premier, if not the premier, geopathology or a society in Asia. And you guys did it just for a matter of months, not even 1 year. So kudos to all of you, to the founders, and of course to the president, who's also my friend, Dr. Jeff. So congratulations, and thank you for giving me this opportunity to speak for you there in Southeast Asia. So I'm gonna share my screen. Let me see if this work. All right, I think you guys can see my screen. Thumbs up. Lita, can you see my screen?
Yes. Yeah.
All right. Okay.
But
yes.
Yeah.
All right.
Now it's worked well.
All right.
Please.
So
Thank you.
So my talk will be centered on the grading of flat and papillary urothelial carcinomas. And the way I'm gonna do it is, first of all, this is gonna be morphologic based. So we're gonna talk about the practical approaches first of the flat and papillary urothelial neoplasms. And along the way, we're gonna brought up and talk about the challenges in making those grading. And then at the last part, we'll talk about recent developments, some of the proposals, some of that already adopted, and some of these are actually controversials in terms of grading urothelial neoplasms. So broadly speaking, urothelial neoplasms can be divided into two. We have the flat, and then we have the papillary tumors. Most of them are exophytic, but they can be endophytic as well. So we have the flat and we have the papillary tumors, and these two categories are pathobiologically distinct. Clinically, they are also treated differently. So it's important that we make a distinction between flat and papillary tumors. Papillary tumors, it's easy for us to diagnose, right? Papilla, we just need this fibrovascular core, and then we have a papillary tumor. Now, if you look at the recent WHO, the latest WHO classification for the flat lesions, we have only two tumors there, or two neoplasms. Urothelial dysplasia, which has an asterisk, which is very controversial. There's some problems with reproducibility, but it's there. It's at the low-grade spectrum, and then you have the CIS. On the other side, in the papillary tumors, you have these 4 categories, 4 differential diagnoses. So before we jump
in progress.
Before we jump into grading, we have to have our foundation, right? We have to have our baseline. And the baseline that we'll be using is that we have to master the normal urothelium, how it looks like. Then we can understand the spectrum of progression up to the highest grade. So normal urothelium, usually less than 9 or less than 10 cell layers thick. Then you have the umbrella cells right there at the surface. The nuclei, as you can see, they are ovoid nuclear shape. And I use the word polarity to describe this. So basically, they are perpendicularly aligned, and then the umbrella cells are going to the other direction. So remember this T-shaped relationship, this T. It will be useful, this T-shaped relationship later when we go to some of the categories. And then polarity is also basically just the cells are aligned perpendicular to the basement membrane, they're going to the top. Now, there's also this maturation in the normal urothelium. Right now, we're in a low power view. If you see the distribution of the nuclei, they are more crowded at the base. Then there's a little bit more spacing towards the surface, spacing in a way that it's more pink, right? There's more cytoplasm. So it's kind of, the cells have more cytoplasm. So there's dense, and then it becomes more, there's some separation going to the surface. And the nuclear details are fine. They are not coarse or they are not granular. So if you look at carcinoma in situ on the other side, then you lost most of those features. Nuclear are large, round, irregular, and then the nuclear details, they are coarse now, and then there's nucleoli, and then there's mitosis. Nucleoli is very important for CIS. So this is an example of carcinoma in situ. So basically, it's defined as having an unequivocal high grade. It's high grade cytology. Now, grading, so we're going to go on with this grading. We have to keep in mind that grading relies on cytomorphology. Architecture can be helpful, but it's pretty much cytomorphology. Now, there are different features that are listed there, but I want to point out 2, because this will be important when we go to the distinction of CIS versus atypia. You have this irregular nuclear outline. So the nuclei first are enlarged, then there's irregularity in the outline, and then the chromatin are darker. They are coarse. Look at the background lymphocytes there and see how the nuclei are big, right? You can fit like at least 5 or 6 of those lymphocytes in those enlarged nuclei. And you guys have no problem calling this as carcinoma in situ, to the left and to the right, right? You can see this loss of polarity overlapping enlarged nuclei, and then their outline is irregular. It's really dark inside, right? The chromatin is really granular. So for going back to the normal urothelium, if we do staining, and these are the 2 stains that I use, CK20 will highlight the surface umbrella cells, whereas CD44 is opposite of CK20. It will highlight the baseline proliferating cells, the basals and the parabasal cells. And these are the 2 stains that I used in the distinctions of CIS and reactive atypia. But I want to make a big point here. I want to make an emphasis that I use these stains in only 5% or less of my cases. The vast majority of grading is based on morphology. It's a morphological diagnosis, all right? So when I use the stain in challenging cases, especially CIS versus reactive atypia, CK20 will have this full thickness staining, whereas CD44, it has this basal staining. So basically, if you conceptualize it, the proliferation of CIS is something like from the top down, okay? From the top down, CK20 is spreading. The third stain that I use is P53. And in the context of CIS, it will have a diffuse nuclear staining. We use the word diffuse for something like more than 50% staining. So diffuse, or it's totally absent, zero staining. We call it as the null staining. So either diffuse or absent. If it is in the middle, like say patchy, less than 50% staining, so that's not going to be helpful for CIS. All right, so what are the challenges that we encounter in CIS? You know, if we have this full thickness pleomorphism, it's a problem, right? But that's not always the case. CIS tends to denude. That's why we see it in urine cytology. And sometimes we have this denuded urothelium. And actually, if you have a denuded urothelium, you have to be cautious because CIS can denude. And if you see this enlarged cell, look at the background lymphocytes there, you can, relative to the size of this enlarged nuclei, right? So that's helpful. And you can see that you see this enlarged nuclei. And if the nuclei are enlarged and they are at the close to the basement membrane, then that's concerning. If you go back to the normal urothelium, those umbrella cells can have pleomorphism, but they are far away from the basement membrane. But if you see large cells next to the basement membrane, even if you have a full thickness urothelium, you know, like that's a problem. So this is clinging CIS, and it's confirmed by CK20. Another problem is this pagetoid CIS, because it can have a patchy involvement of the urothelium. Some of the cells are spreading, the urothelial carcinoma cells, some of them are clustered. And going back to my point about these atypical cells, if you see like big cells, right? So pleomorphism can happen with umbrella cells, but if you see big cells immediately next to the basement membrane, that's abnormal, right? That's abnormal. And pagetoid CIS can be subtle, as you can see in the example to the right. So you can confirm it with CK20 in this case. You know, this is a rare scenario that you have this kind of really focal CIS changes there. But for the most that I've seen, it's usually kind of diffused. And if you go around actually with pagetoid CIS, at least from my experience, you will see associated kind of usual conventional type CIS, you know, if you look at the other fragments. Another challenge is that CIS can go down into the Wundt-Brunn's nest. And diagnostically as a high-grade neoplasm, it's not going to be a problem. But the problem here is it can be misinterpreted as an inverted papillary urothelial carcinoma. Now, at the very beginning of my talk, I emphasized that flat versus papillary is an important distinction. Clinically, when we say something like flat, it tells the clinician that we have likely a diffuse process. So from the perspective of something like staging, it's going to be a diffuse process. So they think that CIS is more is prognostically bad compared to a papillary tumor or an exophytic tumor, which can be localized, and it can also be multifocal. So it's important to distinguish a CIS, and in this context, it's CIS versus an inverted papillary urothelial neoplasm. Now, there can be isolated Wundt-Brunn's nest involvement, and usually this can happen in post-intravesical therapy setting. But the biggest challenge, as we know with CIS, is reactive urothelial atypia. Why? Because like CIS, polarity is lost, cells are crowded, mitosis is present, but it's only basal or mid for the mitosis, nucleomegaly, and prominent nucleoli. I bolded prominent nucleoli there because that's really what connects CIS and atypia. You know, if you look at the literature, if you look at the textbook, it's always CIS versus atypia, right? Because of the prominent nucleoli. Dysplasia, in contrast, does not have this diffuse nucleoli. So it's always like you think about CIS versus atypia, not atypia versus dysplasia, right? Now, what's the difference? So if you take out, you know, imagine looking at this, right? And you imagine like you take out this prominent nucleoli, pluck it out, you know, getting a spoon and kind of taking it out. What's left with the nuclei is you just have basically this evenly distributed fine chromatin, as you can see here, right? And then the outline is relatively more regular compared to what you see in CIS. And of course, associated inflammation, usually acute inflammation is there, and check the history for stones, infection, in what context this usually they present with hematuria, right? That's the indication for biopsy or cystoscopy. What the history is, there's any something there that can be an insult to the bladder mucosa that can cause these reactive changes. So history is very important. Another example of reactive urothelial atypia, you can see this in the nuclei, relatively have a smoother outline. You can see the prominent nucleoli, but again, the background chromatin is fine. And in contrast, compare CIS, you can see the color, right, of the nuclei. It's really different, right? This is the granularity of the nuclei is there. And of course, in the background, you can see some of the inflammatory cells associated with reactive atypia. So for staining, the staining of atypia is opposite to that of you see in CIS. So CK20 can be retained in the umbrella cells or they can be lost. And in contrast to CIS, there will be full thickness CD44 staining. So this is a basal proliferation, right? So this is kind of a proliferative process, reactive. So it's the basal cells, or where the stem cells are located, gonna proliferate to the top. So CD44, as you remember, is staining the base, so it's going up, right? So it's opposite of CK20. CK20 in CIS is staining downward, right? So that's it's easier to conceptualize this way, so it's easier to remember. Now let's look at this challenging case. So this is a TURBT, and you can see some differences here of the morphology, cytomorphology in particular. To the left, you compare it to the right. In the right, you can appreciate what I said is polarity, right? Look at an oval shape pointing to the top. Now here, you have the rounding already, right? Once you have the rounding, then that's a sign that something is going on. And then you can see the polarity, right? They are lost, right? They kind of, they are not as perpendicularly aligned, right? Or arranged nicely going to the surface. If you zoom in, and you start to see the prominent nucleoli, there's two mitosis there. So this is something that, say, oh, this is CIS, right? Because it's more than for dysplasia. Now, if you want to stain this, then CK20, as you can see, you see the contrast, right? At the area of the CIS in contrast to the area of non-tumoral urothelium, which shows absent CK20 staining. Another case here to show the contrast of CIS and reactive atypia. So to the left, you have the CIS with its large pleomorphic disorganized nuclei, and then you have the reactive atypia right there on the right side with the background inflammation, and you can see that the contrast of the nuclear changes in particular. So the other challenge is also radiation-induced atypia. Now, in radiation-induced atypia, there will be pleomorphism of the nuclei. There will be smudgy chromatin and vacuolation. But one feature of radiation-induced atypia is usually this is a diffuse change. This is a field effect, right? When they radiate that area, so that it will be more widespread. Usually, but not always, urothelial neoplasm can be like focal, right? Can be like you have different patches of CIS, and then in between you have this kind of normal-looking urothelium. In radiation-induced atypia, the whole area will show that changes, and not only the whole surface, also underneath. Like if you look at the endothelial cells, the stromal cells, they also exhibit atypia. Now, if this is really challenging, right? So I use IHC, and IHC CK20 is very helpful here. Among those three things, by the way, CK20, CD44, and P53, if I kind of put that into importance, which are the stains that has to be the most important, I would put CK20 first, and then P53, and then CD44. And that's my order of stains. And it depends on the degree of difficulty. Sometimes CK20 alone is good enough in those really challenging cases. Going back to these cases, so this will be this case. So this will be CK20 diffusely positive. And of course, look at the history. These cases will be seen in post-radiated patients, obviously, right? So, and most of these patients are usually prostate cancer patients who had prior radiotherapy. Now, I want to show urothelial hyperplasia there. We're talking about grading here. But the reason why I'm showing urothelial hyperplasia is this going to be an important criterion once we are looking at the papillary tumor, right? So for urothelial hyperplasia, basically, it's a markedly thickened urothelium without any atypia. So the oval shape, this alignment of the nuclei towards the surface will be there. So it has this very, very nice alignment. Now, if you ask me what is the cutoff for to call it hyperplasia, we don't have a cutoff. So basically, hyperplasia is markedly thickened, thick enough that it attracts the attention of the urologist during cystoscopy to biopsy that site. If you start to count the cell, hey, this is 10 cells or more, likely you're not looking at the urothelial hyperplasia. Probably it's just tangential cut. When it's hyperplastic like this. And again, just to emphasize, this retained alignment of the oval shaped nuclei pointing to the surface. That's why you have this beautiful polarity, and that's for urothelial hyperplasia. And keep this in mind when we go to our criteria for for grading of the exophytic or the papillary urothelial neoplasm. Now, this controversial entity of dysplasia, and it's controversial because of this poor reproducibility, and this is really because even the definition is subjective. So basically, it's a neoplasm that falls, that diagnostically it falls below the threshold for CIS, right? So it's right there in the middle of normal and CIS. So there's some subjectivity in this. So the clinical significance is poorly understood, and but the good thing is that most of the dysplastic lesions are encountered during follow-up of patients who are initially diagnosed with urothelial neoplasms, usually the papillary tumors. They are seen or encountered there during follow-up as a de novo, as a secondary dysplasia. De novo dysplasia is rare. So in that context, it's encountered there in that scenario. So it really has no known treatment implications. So that's why, even if we have poor reproducibility, it doesn't really have that bad effect clinically. So morphologically, how is urothelial dysplasia? So basically, it's in the middle, right, of normal and CIS. So you look at the nuclei. So if you go back to that spectrum, the very first slide, very first few slides that I shown between normal urothelium and CIS, you see the spectrum, right, of the oval shape nuclei. So it's going to be here. You're going to start to see the rounding, right? You're going to start to see the disorganization, the loss of polarities there. And you see this kind of randomness of the changes. So it's not enough. And then one thing that I like to emphasize here between urothelial dysplasia and CIS is that the nucleoli is not diffusely enlarged. In CIS, usually you see this. It's when you look at the case, the nucleoli will stare back at you. So that's more towards CIS. All right, so that's for the flat lesions. All right, so but we have to keep to remember this criteria or this morphologic features that I described when we go to papillary tumors, because there's this analogy. So papillary urothelial neoplasm, they are important to be distinguished or to categorize. We have 4 categories because, as you can see here in the table, the recurrence as well as their progression is different. So recurrence rate increases with grade, so as progression. And you can see that papilloma has basically nil chance for progression, but panlump has 4% chance of progression. Now, if you look at the recurrence rate, it's really high even for panlump, right? So this is they recur. So that's why this patient are usually put onto active surveillance cystoscopy. So let's go to the fun part, and this is what I like about this analogy of the flat and papillary lesion. So they are categorically, they are different, pathobiologically, they are different. But we can use the criteria in flat to diagnose the papillary lesion, right? So if we have the normal urothelium, and basically the difference between flat and papillary tumors is the presence of this fibrovascular core, right? So if you have a normal urothelium, you put it in a core, that will become a papilloma. Okay, hyperplasia, you put it in a core, it becomes a pun lump. Dysplasia, that changes, that borderline changes, it becomes a carcinoma in the context of the papillary core, becomes low grade. CIS, of course, becomes high grade, right? So now let's show this example. So basically, you have normal urothelium, you put it in a papillary core, the umbrella cells, it should not be thickened, okay? Not hyperplastic. That FVC there, by the way, that's a fibrovascular core. So with a fibrovascular core, then you have this urothelial papilloma. Now, hyperplasia, of course, the difference between normal and hyperplasia is that thickened urothelium. So basically, the difference between pun lump and papilloma is also thick urothelium. Once you have a thickened urothelium in the context of papillary tumor, that is not a papilloma. It's at least pun lump once it's thickened, right? And it maintains this beautiful polarity, just you will see in hyperplasia. And then you have some rounding of the nuclei, kind of random pleomorphism. Then it becomes a low-grade papillary urothelial carcinoma if it is present in a fibrovascular core. Now, going back to thickness, low-grade and high-grade may also not be thickened, okay? It may not be thickened, but you will see this pleomorphism or changes that is different from that in a papilloma. Now, for high-grade, of course, you have CIS, you put it in a papillary core, then that becomes a high-grade papillary urothelial carcinoma. So what are the challenges that we have when making a diagnosis of papillary urothelial carcinoma? So one is that sometimes it can be truncated, it can be cut, like usually it can seem like, say, instrumentation or like after intravesical therapy, the top is cut. And if the top is cut, right, so now you have a flattened surface, and this can be misdiagnosed as a CIS. Again, I like to emphasize distinction between flat and papillary is important, including clinically, it's important. So in this case, it's flat surface here, but you can appreciate here this fibrovascular core. And you can see that the vessel, this is an important feature, the vessel reaches the end, the tip of that core, as you can see here, and that's helpful. This is a true papilla. So this is a papillary urothelial carcinoma. This is not a CIS. Okay, so that's one challenge. The other challenge is this undulating. Sometimes they have undulating surface, right, or mucosa, and you can see hyperplastic urothelium there, which is kind of bland, right? Not neoplastic looking. This is papillary urothelial hyperplasia, and you can see end to end. You can see the changes. It's not. It's more like we call it tenting. It's like a tent. It's not really like a delicate slender papillae. And this is papillary urothelial hyperplasia. It can be mistaken as a low grade or a pun lump lesion, but this is a papillary urothelial hyperplasia, and it's suggested to be a precursor of low grade papillary urothelial carcinoma. So we talked about these exophytic tumors. Now, these exophytic tumors can also grow inward as an endophytic tumor, basically with inverted growth, right? So let's talk about inverted growth because it's a challenge. So first, let's define inverted growth. What is it meant by inverted growth? Inverted growth is not an invasion, okay? It's just that it's spreading or pushing downward, but not, and the basement membrane is still there, but it's not invading the stroma. So this is characterized by this regular, rounded contour, and the boundary between the epithelium and stroma is sharp. Okay? And then there's no dysplasia, of course. And you wouldn't see those jagged, irregular nests that you would see in invasion. So it's important, again, not to misdiagnose this as an invasion. So the categories of tumors in the inverted urothelial neoplasm spectrum is the same as the one that we have in the exophytic category. So we have inverted papilloma, then we have pun lump, and then the low-grade papillary carcinoma and high-grade papillary carcinoma. And we use the word with inverted growth. This is a terminology now that is mentioned in the latest WHO. So we have to put the tumor and then with inverted growth at following that. So let's distinguish these four lesions with inverted growth. So we talked about how they differ exophytically, but now let's talk about them in the context of inverted tumors. So inverted papilloma. There are three features that I want you guys to remember about inverted papilloma. So first of all, it's an inverted growth, right? Because we're talking about inverted tumor here. So there's no exophytic component. It's just purely endophytic. One feature is that it has to have thin trabeculae. Now we keep on going back with this thin and thick, right? Normal and hyperplasia. So this is inverted papilloma. It has this thin trabeculae, and it has, if you look at closely, it has this beautiful streaming, central streaming of the cells. Okay, you can see it in the thin trabeculae, and it has this peripheral palisading. So thin trabeculae with cells that are centrally streaming with peripheral palisading. Those are the three features that we have to remember. And of course, cytologically, they are low grade. And just to make it easy to remember, why are they have this arrangement of streaming and palisading is because basically inverted papilloma is an inward growth of normal thickness urothelium. They are opposed. And if you look at this closely, why they have this central streaming, if you remember the T features that I showed in a normal urothelium, the umbrella cells, and then you have these other cells in the base and the parabasal area. So basically, the central cells represent the umbrella cells, and you have these two opposed urothelium now. So you have this normal thickness, right? That's why you have to have this thin trabeculae. Now, in the context of inverted tumors, once you see expansion, right? If you see expansion like that, if you see that expansion, you are no longer in the realms of inverted papilloma. You have to kick that inverted papilloma out. It's no longer in your differential. So at least now you have a diagnosis of punlump, right? Of punlump. So just like in the exophytic tumor, if you see a thickened urothelium, then papilloma is out. Here, inverted papilloma is out. So this is at least punlump. Now, how are you going to categorize this? Again, we go back to cytomorphology. That's the foundation of grading urothelial neoplasm. Look at the cytomorphology, the nuclei. So you have punlump, you have low grade and high grade. Look at the nucleoli of high grade. They're staring back at us. It's easy to pick up. And that's a high grade papillary urothelial carcinoma. And again, make sure that we are looking at an inverted growth. Sharply demarcated, rounded contour, no desmoplasia, no small jagged nest. This is an example of a low-grade papillary urothelial carcinoma with inverted growth. You can see the nuclei there. There's some of the nuclei are rounder, disoriented, but the nucleoli is not that diffusely prominent. There's high grade, more rounding, more crowded, more pleomorphism, and you can see the nucleoli here. And then there's mitosis there as well. It's kind of brisk, as you can see. All right, so how do we distinguish inverted papillary versus invasion? And this is like a classic, difference here. So you have the inverted there, we have kind of this rounded, sharp, demarcated inward growth, and then the invasive urothelial carcinoma. So they have irregular, jagged nest. If you find single cells, that's really helpful. And also helpful is this squamoid features. Basically, they have more cytoplasm. And that we call this as paradoxical differentiation. In a paradoxical because in a normal skin, right? The more the cells are closer to the surface, produce keratin, but here it's the other way around, right? There's more keratin production going inward. So we have this kind of paradoxical differentiation. And if you see single cells with paradoxical differentiation, then I can sleep, with calling that as invasive. I'm very, very confident. So what are the challenges in the inverted growth category? So Brun-Brun's nest can be a problem, right? Brun-Brun's nest, because they can mimic this inverted growth, right? So they can be a differential diagnosis for low grade or punlump. So what's the difference? So unlike the low grade or punlump inverted tumors, florid Brun-Brun's nest is purely endophytic. There's no exophytic component to it, right? Keep in mind that florid Brun-Brun's nest can extend deep into the lamina propria, almost approaching the muscularis propria. It can happen. And they are rounder with nicely spaced area. And what's really helpful is that if you find this well-differentiated intestinal features of the cells, like cystitis glandularis in particular. If you have that, that's very helpful, right? Because you are really looking at the spectrum of Brun's nest, cystitis cystica, cystitis glandularis in the back. So that's really helpful. All right, so let's take a brief moment here and assess our reproducibility. Okay, I know you guys are probably sipping your wine there in Southeast Asia, and here I'm sipping my coffee, right? So what we're gonna do now is let's assess our reproducibility here. So just sit back and relax, and in your mind, think of your diagnosis. So this is a papillary tumor. Look at the features now. So the cells, they are a little bit round. They are prominent nucleoli. It's not, you can see nucleoli, right? But probably not diffuse. So I would call this, and you guys have your own diagnosis, I will call this as a low-grade papillary urothelial carcinoma. Okay, another lesion here. Now, this is different from the first one. Right? Striking right away, right? Nucleoli, that should be like the key, like nucleoli. You look for those right away in the context of this enlarged round nuclei. Obviously, this is high grade, right? All right, next, again, papillary tumor. And for papillary, you really have to have this fibrobascular core. And it's a beauty, right? Look at how they are nicely polarized, right? Like basically, if you put this in the context of a flat lesion, it's like hyperplasia, right? So this is a pun lump, okay? Another papillary tumor. So the umbrella cells are actually right there right away at the get-go, right? So the umbrella cells, this is not thickened, right? Not as thick as the previous one. So we're looking at papilloma, and there's no atypia here. So it's basically like represent kind of equivalent to normal appearing urothelium. Now, the last two cases are a bit more challenging, challenge us. So we'll see. All right, so this one, it's a papillary tumor, and it has some enlargement, some prominent nucleoli. So it's there already. So what are we gonna call this? Do we have enough here to call it as high grade, or this is just low grade? So basically, pun lump is out here, papilloma is out. So we basically just down to low and high, right? So in this case, I really have to convince myself more to call this as high grade. So I'm calling this as still in the realms of low grade. In the old classification, this is probably the grade 2, right? But for me, this is not enough. And just for comparison, this is what I'm going to call as high grade. This is a little bit easier. This is a high grade papillary carcinoma. As you can see here, they're more rounding. They're more, the nucleoli is more prominent, and there's more pleomorphism, mitotic activity. So if you compare, let's go back, that's low grade, and then this is high grade. All right. Okay, so let's move on to the last part, recent developments. And I'm gonna discuss these 4 topics. So grading with mixed grades, then the early papillary formation, then this concept of shoulder of papillary tumors, and then this recent proposal, which is controversial, to report both the 2004 and the 1973 WHO grades. So let's start with number 1. So this is a TURBT, and it has basically a papillary growth, exophytic, and then for the most part, the tumor shows this morphology. So it has kind of some polarity there, a little bit of rounding in some areas. And so it has the feature. And focally right there at the circled area, you see the contrast there of the cells. They're more rounded, prominent nucleoli, right? So that's clearly high grade. So you have focal high grade here in the predominantly low grade papillary urothelial carcinoma. So now the question is, how are we gonna make our diagnosis now? We have a mix, right? So so here, the amount of high grade matters. So for the WHO now, they recommend a 5% cutoff. If it is 5% high grade, it's only 5% or less, then call it as a focal high grade. 4 years ago, we and ISOP also had our consensus, and we couldn't come up. We will consider 5% also as focal high grade, but our cutoff goes as high as 10%, meaning that if you have a mixed grade tumor and high grade is more than 10%. If high grade is more than 10% in a tumor, then just call it, you can call it as a high grade. Basically, that will be a high grade papillary urothelial carcinoma. Of course, there's subjectivity here, right? Of course, what's 5%, what's 10%, right? It can vary, so even, intra-observer, it can vary. But, if it's only focal, then call it focal high grade. To address this, how we are recommending it in ISOP is that call it as predominantly low grade with focal high grade and put the percent there. Now, why do we have to make a distinction? Why do we have to distinguish this? The reason is that these tumors, these low-grade tumors with focal high grade, have behavior intermediate between low grade and high grade. And importantly, from the treatment perspective, unlike low-grade papillary urothelial carcinoma, this will respond or benefit with intravesical BCG. So these patients should be given intravesical BCG. That's why it's important to keep that high grade there in your line diagnosis. All right. So this is one of the novelties that it's already in the WHO Blue Book. Now, one aspect, it can be a challenge, So as I emphasized at the very beginning, at the get-go, it's important for us to distinguish flat versus papillary. But sometimes, we have papillary urothelial carcinoma with really small papillae, right? It can be a problem. And for papillae, so what are the clues for me that it's a papillary tumor? So one is that if the urothelium is thickened, meaning that I'm not thinking of CIS, right? So more papillary carcinoma has thickened urothelium, but not always. Okay, it can also have thin urothelium. Now the core should be slender; it's not tented. And then to call it papillary, the vessels, as I already alluded to earlier, the vessels should be reaching the tip of the core. So for me, based on this morphology, this is a small papillary urothelial carcinoma, and obviously it's high grade. Now there will be changes like this, and then we struggle. Is this a papilla? Is this not? It looks like a papilla. So to me, actually, this could be enough already to call as a papillary urothelial carcinoma. But some groups, especially if you are challenged, if you have difficulty, you can use the word CIS with early papillary formation. And it's kind of a pause there, that early papillary formation, that you may not be dealing with a papillary tumor, a CIS, but rather it could be a papillary urothelial carcinoma. Of course, you have to make some comments here to explain your diagnosis, that this could represent a papillary urothelial carcinoma and not really a flat CIS. So some are proposing this terminology, but it's not really, there's still a bit of controversy here. All right, so the third aspect that I want to discuss is this concept of shoulder of a high-grade papillary urothelial carcinoma. So if you imagine a papillary urothelial carcinoma, the neoplastic growth does not stop right here, right? It extends laterally. And those areas, we call it as the shoulder of the papillary urothelial neoplasm. Now, when they do, the standard now is when they do a TURBT, and it's turned out to be at least high grade, they have to do what we call as the repeat or second TUR. They have to come back and do a second TUR, and the reason for that is that it lowers the risk for the chances of recurrence. Right? So there's a benefit of second TUR. It's a standard now. So if we go back to the lesion, so the first TUR, they take this out, and some of the shoulder will also be taken out. So you will have a papillary lesion, and then you will have a flat lesion look-alike, basically, in that specimen. Now, on the second TUR, if there's some residual neoplasm there, then only the shoulder will be captured. It will look like CIS if it is high grade. So let's go to this example. This is a first TUR. So you have this papillary tumor right there. Okay, so they basically have this vascular core. And then in some of those fragments, you can see some that are flattened, right? So don't to me, in this context, I would hesitate to call this a CIS because there's a little bit of thickening here. And then it kind of, I could associate these changes to basically to the exophytic papillary growth. Now, why I am very cautious here of calling it CIS, and the reason for that is that if you look in the risk stratification, in the risk stratifications, once you have a high-grade papillary urothelial carcinoma plus CIS, that put the patient at the highest risk category. And in fact, in some, if it turns out to be a P1, like lamina propria invasive tumor, and then you report CIS as well, that will be in the highest risk category. In fact, cystectomy can be considered as a management for those cases. So you have to be very careful in overcalling CIS in the context of a high-grade papillary tumor. So important here, and what I do in my practice is I correlate it with the cystoscopy. If the surgeon is dealing only with one lesion versus like one lesion, and then there's some flat changes, some changes, especially with the blue light cystoscopy, and it happened that he put all the specimens in one container, then I would think that, oh, probably it's a CIS from another area. So this is the challenge that we have in the first TUR. Now, with the second TUR, you see something like this, right? Just a flat, looks high grade, basically high grade. So it could be CIS, but this could also be a shoulder. So if you see something like this next to the ulcer, next to a prior TURBT site, so if it's next to the ulcer, I don't commit if this is CIS. I use this terminology. I use the non-invasive high-grade urothelial carcinoma, and then with the comment that this may represent a residual component of a previously resected papillary urothelial carcinoma from this side. Of course, it's important to know that there was a previous, if you check the history, this patient about previous urothelial carcinoma that was sampled. Usually it's about in the range of about a month or 2 months ago from this, the previous specimen. And then come back, and then you have this ulcer, and then next to it, you see these changes. And I avoid to call this as the CIS. And finally, quite controversial is this using the grade, the 1973 grading system, and then the current 2004, which is basically adopted in the latest WHO Blue Book. So if we look back at the 1973, so basically we have grade 1, grade 2, and grade 3. And they are not perfectly aligned with the current grading system. So if we look at the high grade, so high grade basically has some grade 2, and all the grade 2s went to high grade. So meaning that high grade has a spectrum. And there's data to support this. There's data that shows that if you break high grade into grade 2 and grade 3, there's actually prognostic difference. So basically, the point there is that you can identify the highest risk, the high grade G3, that they are more prognostically worse than a high grade G2. So there are now groups that are proposing to have this reported. And this is actually, so in terms of, like how is this adopted? So to me, this is really, the proposal is there, but the practice remains varied. And I think this is about also geography. Like, like here in the US, we are using only the latest WHO system, but in Europe, they're using also the 1970. They use both. Like in our guideline here in the US, the urology guideline, they only follow the high grade, low grade category. But in other parts of the world, they are also using the 1973, like in Europe. So going back to us, just in case, your surgeon asks or your urologist asks, like, is this grade 2 or grade 3, this high grade lesion? So we have to understand that a high grade, as we're calling it, really has a spectrum. So, I'm not using this 1973. So at least from my understanding, this is probably the best example of a grade 2 based on the 1973 grading. You still see some nucleoli there rounding, right? But the grade 3 obviously is much worse. So I would call this as high grade, grade 2, and this is high grade 3. But both of them, in my practice, I would call it as a high grade. And at this point here in my institution, we don't make this distinction. And that will be my last slide. So thank you for this opportunity. And it's a pleasure for me to present. And I'm happy to take questions.
Yeah, thank you so much, Professor Gladel. Thank you. I love your presentation. I hope all the participants also, because I do realize, and maybe also other pathologists also students facing this as our daily practice. And nowadays, since the urologists trying to do minimal invasive, am I correct? Then sometimes they send us also very limited tissue. Then it's kind of like a mystery that we have to come to them with the final diagnosis, and they really depend on us. I think that's what I do feel. I don't know for others, maybe the same. And then maybe you also well known that in our Southeast Asia region, we do face some limitation to perform the additional examination. So we always have to deal with the things. Okay. I will check. There some question, I think. Yeah. I think you can also see, yeah, I think we have first question. So, Professor Gladel, if the cytology is in between the low and like grade 2, it will be included under the low grade or high grade. Kindly suggest, please.
So if it is if it is low grade with prominent nucleoli, or the I didn't. Oh, here I can read it here. If
Yes, you can read
cytology is between
from the
low
chat.
and like grade 2, would it be included under low grade or high grade?
Yeah.
It's in between low and like grade 2, so that will be a low grade. All right. So we made a clear distinction between low grade and high grade. And as I said earlier, one of the features that I look into is the nucleoli, the kind of the prominent nucleoli is should be there, it's easy to find. And then mitosis, they go to the surface. That's for high grade. Low grade, usually they are at the mid or at the base. And, so low and high, so that's the distinction of low grade and high grade. Unfortunately, if we extrapolate, that's why you have a question, the old grade 2, some of them became grade, some of them become high grade, some of them becomes low grade. But as long as we stick to that criteria, we follow that. So, so that grade 2 will be split. It can be low grade, it can be high grade, but we have to keep the criteria that we already talked about. So, so the answer for this is that in between low and like grade 2. So just based on this description, I would err towards calling this as low grade.
Okay, so I do hope that Dr. Srilika Apasani is still with us and also understood the answer. Now from Dr. So, Dr. Jeff also have a question. I know that this is, maybe you can just check it, Professor.
Yeah, so I can read it now. It's beyond the scope of your lecture. But is there anything new in terms of differentiating adenocarcinoma of the bladder, gastrointestinal malignancy invading the bladder, any new IHC? So unfortunately, there's none. But there are ways, right? So differentiating adenocarcinoma of the gastrointestinal tract, particularly the colorectal adenocarcinoma versus the bladder adenocarcinoma. And when we say adenocarcinoma in the bladder, it can also be pure adenocarcinoma of the bladder, or it can be adenocarcinoma mixed with urothelial carcinoma, what we call as urothelial carcinoma with glandular differentiation. So let's divide my answer into two. So first, distinguishing colorectal adenocarcinoma versus urothelial carcinoma with glandular differentiation. That's easy, right? Because you just have to look for urothelial carcinoma component, and that's it. It's pretty much like a morphologic diagnosis. To find urothelial component, look at the surface, CIS or exophytic papillary. So that's easy. Now, going back to this question, pure adenocarcinoma of the bladder versus colorectal adenocarcinoma, as I already said, unfortunately, there's no stain right now that we can use. The only stain that still holds, and this was started about more than 20 years ago, and actually it started here in this institution, University of Chicago, is beta-catenin. Beta-catenin can be useful. It is lost. It can be lost in colorectal adenocarcinoma, but it can be retained in pure adenocarcinoma. No, I'm sorry. It's the other way around. It should be expressed in colorectal adenocarcinoma. Now, the problem with using beta-catenin, and it's not commonly used, is because of it's a difficult stain to interpret because it's ubiquitous. It can be picked up by the cytoplasm. So picking up this expression or loss, it's challenging. So that's why not many use it. It is because of the technical difficulties. But going back to the question, the answer right now is at least to my knowledge, there is no new IHC.
Okay, thank you so much. And we'll move on to the next question. Maybe you still have time.
Oh, yeah, sure.
Yeah, from Dr. Yang Jun Wang. Is there any consensus on shoulder lesion, Professor Gladel?
No, so that's the problem right now. It's still kind of this is evolving. We discussed it last year in the eyes of Florence consensus, and it's still there's some controversy, and really controversy happens when we don't have data, right? Data speaks, right? And in this kind of context, we know that it's there, but no one has really studied this into details, right? Like what's the significance of this? If you have this residual shoulder lesion, what will be the prognostic outcome or something like that to that degree, right? That's a problem we don't have, but we know that it exists. But we also have to do something at this point, right? We have to be cautious. And the cautiousness that we have to do is not to overcall it as something like put this patient in the category of high risk by labeling this patient as having concomitant CIS and papillary urothelial carcinoma, when likely we know just based on our morphologic analysis is probably like we're just dealing with one lesion. It just happened that the specimen is fragmented, or just because on the second TUR there's a residual shoulder there that is still part of that initial high-grade papillary carcinoma, that there's a chance that we're overcalling it and over-labeling this patient as a high-risk patient. So we have to be cautious. But it's still controversial, as again, going back, because there's not many studies on this. So it's something that has to be, you guys, you have a good society now, good collaboration, right? So something like this you can help address, there's a lot of questions in GU that needs to be answered. So, and that's why I'm glad that there's society like SEAUPS, so more people can study this can answer these questions with doing research.
Yeah, regarding that question, still, the physicians somehow are not endorsed yet about this problem. How do you suggest or
Yeah,
explain
so it's for us not to overcall it. The key point here is not to overcall it. Don't call it a CIS if you are not certain that it is CIS. It's just for us to speak that, and so the clinicians will see that we're explaining that this is not CIS. So let me give a scenario. For example, a patient have a papillary carcinoma, high grade, it recurred, then it becomes a high grade invasive into the lamina propria. Categorically, that will be a recurrence as a T1 disease. Now, if we call something as a CIS, say the shoulder, on that diagnosis of a T1 tumors, in the European standard, in the EAU guideline, if you have T1 plus CIS, that put the patients into the high-risk group, And the cystectomy is it can be an option in that category. But, if we look at it and we see that, is this really CIS or not? We have to pause, right? It tells us to pause. We have to make sure that it's just really If we are definitive that, hey, this is CIS, then call it. But if we are not, then we should hesitate a bit, because what happened is that if the urologist is really kind of following the guidelines, right, strictly, and then this patient has a chance to be overtreated. So we have to be careful. And that's the point that I'm making here. Of course, it's controversy. It needs really some, a lot of some kind of thorough examinations of the specimen. But my point here is to be cautious. And if you're not sure, show it around, right? Like if this is really CIS or not. And I would admit that this is not an easy way of this. This is an easy diagnosis. It can be difficult, So just a follow up. I'm going to ask myself for a follow up of this. So, like, say, the next question will be: so how do you make a distinction, right? If you have, say, a papillary tumor, can you make a distinction that this is a CIS? CIS happens in this context, that you can still make a diagnosis of CIS in the same specimen? The answer is yes, of course you can, because it can coexist, right? Papillary tumors and CIS can happen. It doesn't mean that it's a shoulder all the time. CIS can happen. So when would I call it a CIS? So for example, in multiple pieces of TURBT, you have these fragments containing papillary urothelial carcinoma. Now in other fragments, separate fragments, you see this very flat, long involvement of the surface, not thickened. Because papillary tumors, if it is a shoulder, it's usually thickened because it kind of follows going up there to as a continuity with the papillary growth. If you have multiple fragments, diffuse, flat involvement, then that's CIS. What's really helpful, if you find something like pagetoid spread will not happen with papillary tumor. That's a CIS, so that's a helpful feature. If you have Brun-Brun's nest there and it's kind of going down to Brun-Brun's nest, that's a feature of CIS. That's not a feature of papillary. So there are clues that it can still happen that in the same container, you have this papillary urothelial carcinoma with concomitant CIS. But my advice is be cautious, set your standard high to call it CIS because of the clinical implications.
Okay, thank you. Crystal clear. I do believe so, hopefully. Also for
Scenario
Dr.
though is not.
Yeah, sometimes our world is not ideal, right?
Oh yeah.
Indeed. Yeah, we move to the next. I do hope you still have a little
Oh
bit
yeah, yes,
time.
please. It's
Yeah.
early morning here. I'm sipping my coffee, so yeah.
Okay, enjoy it. Professor Gladel, how to differentiate between a high-grade urothelial carcinoma from a metastatic poorly differentiated carcinoma of female genital organ? Please.
So metastatic. So let's from any if it is from the genital tract, right? So probably the closer differential diagnosis will be from the lower female tract, right? Like from the vagina, vulva. I'm talking about squamous cell carcinoma. That will be more challenging.
Yeah.
Going up
from the cervix, prof.
From
sorry,
cervix.
Yeah, from cervix.
Cervix.
From cervix, yes. So since I'm answering, so I just answer broadly as well. So the other parts, so the other parts, Mullerian, Wolffian, that will be PAX8, right? It will be the PAX8 positive tumors. Morphologically, they look different. So going back, so squamous, right? The problem is squamous and distinguishing from bladder. Secondary involvement of the bladder by a squamous cell carcinoma coming from the cervix, coming from the vagina. It can be a problem. Right. But we have to keep in mind, we are not alone in this. That's the first thing that we have to keep in mind. We are not alone in making this diagnosis. We have also clinicians, right? So number one is that, and this is true not only for distinguishing female genital versus urinary tract, also true with GI tract versus bladder. Okay. So the clinicians may see the lesion there. That's one. Yes, we have to that because that is a high stage tumor, so they can see that, and we can correlate our findings there, right? So that's one, so something that we have to keep in mind. We don't have to kill ourselves, right? We have to communicate with them. If we remove that scenario, say we are making this distinction on our own. So how? So morphologically, unfortunately, there is overlap. As we know, squamous cell carcinoma can happen primary from the urinary tract, including the bladder. Morphologically, they can look exactly the same, right? Exactly the same. So from that context, it will be hard to distinguish. Now, but there are some clues, all right? There are some clues. So let's start first with squamous cell carcinoma of the bladder versus secondary involvement with squamous cell carcinoma. Right? So if you have a primary squamous cell carcinoma in the bladder, look at the surrounding mucosa. If you happens to have this normal or non-neoplastic mucosa there, the risk for squamous cell carcinoma is keratinizing squamous metaplasia. You should see the change there around it, like away from the tumor, you can see some keratinizing squamous metaplasia. That's equivalent to dysplasia. That's a precursor for squamous cell carcinoma of the bladder. If you have a precursor lesion there, right, then it kind of helps you. Oh, it came from here, of course, because there's a precursor, right? So that's helpful. So what about, say, urothelial carcinoma with squamous differentiation versus a poorly differentiated squamous urothelial carcinoma versus a poorly differentiated squamous cell? It could be a challenge. But in this case, again, the clue is that you have to look for the source, right? Source. So look at the surface if you have that. If you have, say, urothelial changes there, dysplasia or CIS in the surface, if you're lucky, you'll find a papillary tumor. That will be helpful. So pay attention to the surface. That's very important. Right? That's very important. And of course, if we are trapped, right, if we really cannot tell, then we just have to admit and be honest about it. Again, we're not alone in this. Just put in your report, that at least identify, enumerate the organs that could be possibly the source, and tell that to the clinician to, hey, look at this, look at that, if there's tumor from the area or coming from there, and send us if you see something there, do a biopsy and send it to us. We may see a primary precursor there or something that it could tell us that it's coming from that area, So those are, but in terms of immunostaining, for, say, squamous versus squamous of the two squamous, no, obviously there's no stain. Urothelial versus squamous. Now, GATA3 is expressed in both, so have to be careful, but GATA3 have more diffuse staining. P63, obviously, P40 is stained in both. Now, uroplakin is expressed in urothelial carcinoma, but I don't have much experience with squamous cell carcinoma for uroplakin, so I couldn't recommend or comment about it.
How about P16, Prof?
P16 can be positive in of course, in the female, right? In the female tract. The positivity rate in the bladder is lower. So I don't know if it is positive, how helpful it is. I haven't used that stain to make this distinction.
All right, thank you, Prof.
Thank you. Yeah, I think the discussion about the shoulder lesion is still going on, but please let me jump to the quite different question. So I think from Dr. Nabila Darmawa asking about any clue to differentiate maybe in practical between pan-lump and low-grade urothelial carcinoma.
So pan-lump versus low-grade. So pan-lump, as already said, yeah. So use the criteria. So remember those features in the flat lesion, right? So if you have hyperplasia appearing urothelium, you put it in a papillary core, that's pan-lump. Okay, so you have this oval shape with a very good polarity. So going to the top, that's a pan-lump. Now, if you start to see rounding of the nuclei, remember in the first slide, in the first few slides, I've shown between normal and CIS, right? That spectrum of change. So you have the oval shape, and then you have the rounded nuclei. So the rounding goes as the more extreme rounding and irregularity of the nuclei that's going to high grade. So in between, you have rounding of the nuclei, right? So if you start to see rounding of the nuclei, and then some of the cells are losing this orientation, this polarity, then you start to think of low grade. So basically, just to make it simple, and I try to be try to simplify this as possible as earlier, is that if you see this hyperplasia looking urothelium in the context of a fibrovascular core, that's a pan-lump. Okay. Now pan-lump is rare. Okay, rare, less than 3% of the diagnosis. So if you're making diagnosis of pan lump like 10% of cases, then you have to adjust your criteria. Okay? You have to adjust. It's rare, and also it's not common in patients who are more than 50 years old. Okay, so imagine now what the thing though is that clinically will it matter? And the good thing, it doesn't matter. Okay, so if you have a pan lump, it will be treated like a low grade basically. So for clinicians, it's okay as long as it's not high grade, low grade or pan lump. It's much more important here in the US, this terminology, because pan lump came up as another borderline category, so that the patient will not have a label or a diagnosis of cancer. So pan lump, low malignant potential, so the patients will not be labeled as a cancer patient. So usually in young patient, they will have pan lump. It's not a cancer. So, for insurance purposes and all the stuff, so it's okay. It's kind of helpful for them to have, not to be labeled as cancer patients in having this pan lump category.
Okay. Okay, great. It's hopefully it's clear for
Thank you, Prof.
yeah, thank you so much. And now Dr. Anjana also asking, is the presence or absence of umbrella cell is useful for us to categorize as a papillary urothelial neoplasm?
Helpful to a certain extent, but not always, because it's usually is not seen. So when you are dealing with normal thickness with few urothelial cells, the category of papilloma, then it can be helpful, but not absolutely. If you think about, let's just look at the normal urothelium. How often do we see umbrella cells, right? It's not going to be always. So it's the same thing when we're looking at a papillary urothelial neoplasm. So I wouldn't put much on it, but it can be helpful in the low grade side, especially with papilloma. But no, in pan lump, high grade, low grade, it's not going to be helpful. So my answer is no.
Okay, thank you. And then the next, Dr. Srinivasan asking, Prof, when can we expect the guideline for reporting post-neoadjuvant treatment for the bladder tumor? Do you have any clue?
So that's a good question. So we are actually meeting next week. So we have a consensus conference, ISOP consensus conference in post-treatment effects in prostate cancer and bladder cancer in Vienna. That will be on September 11. So we're gonna discuss this, and we're gonna come up with some statements and recommendations. So hopefully the paper will be out usually like early next year. So we have something cooking.
Oh yeah, the European Congress will held soon, right? Then the
Yes, so
meeting
it's
will
gonna be next week, and parallel to that, we will have our own ISOP expert consultation conference, specifically for post-treatment effects, including this neoadjuvant treatment effects, in the bladder.
Yeah, thank you so much. So Dr. Srinivasan, please be patient. In the few months, you get your answer for sure.
Yeah, but on the side though, if you cannot wait and you need something right now, if you look at the bladder protocol from CAP, there's already a guide there for grading at the post-treatment setting. It's not really required, but it's there in the protocol, the CAP bladder cancer protocol. It's in the CAP website. You can download it for free, so you can just go there and check it.
Oh yeah, from the College of American Pathologists, am I correct?
Correct.
Yeah,
Correct.
okay, yeah, it's free. Please check it there. Maybe you can have some of the answer over there. And then I think this is the last two question. Professor Glader, is there any data on how far a shoulder lesion can extend beyond the stalk?
No, as I answered earlier, no, we really don't have that. So as I said, so when is a stalk not a stalk? When is this flat lesion becomes CIS? It's a big gray zone. But there are already clues that say, so okay, let's itemize it. So what favors a shoulder? I would say it's a shoulder. It's thickened. That's one. So it's the papillary carcinoma is thick, and then you can see this, shoulder on the side. Usually, it's also thick. One. Number two, it's not that diffuse. You don't see it in multiple fragments. It's only like focal, or it can be in like 2 fragments. And or on the other hand, like what about CIS? Like when you're gonna call CIS concomitant with papillary, like say it's not thickened, seen in multiple fragments, diffuse. You can see some parts with pagetoid spread, or you can see some of this spread in the Bunbun's nest. Then that's no longer a shoulder. You're looking at a CIS concomitant with PA. And of course, or a papillary urothelial tumors. Of course, as I said, it's a big gray zone, but we just have to do our best. And again, going back to my point, the most important point is not to overcall it as a CIS. If you are thinking that this could be just a shoulder, it's not a CIS, then don't call it a CIS. And there's one piece of information that also going to be helpful if you're going to be talking to your urologist. Ask them, did you put your mapping biopsy, meaning biopsy from other sides of the bladder, into the same container? Because that would be a problem. They should put those random biopsy in a separate container, because those could be flat CIS, and can also be mistaken as shoulder. Yeah, so yeah, it's a big gray zone.
Yeah, that's important point. I think we have to communicate with our urologist about this to put the samples in a different pot. Then we can provide them with the satisfactory answer, I think.
Yes, correct. Yeah, correct. And also in the context, not even for flat versus papillary, in the context of grading of papillary tumors, sometimes there's multiple papillary tumors, right? And then all of them were put in one container. So say, for example, there's 5 tumors there all in one container. 4 of those tumors are actually low grade, 1 is high grade. Then we're going to be labeling all of them as high grade, because they are just in one container. When we put out the report, we will say fragments of high grade papillary carcinoma. From the clinician's perspective, there's going to be like a high grade tumor all over the place, but in fact, it's really just 1 high grader out of the 4. So we need more clarity for this. The problem is it's not standardized, and this is something we still have to work on.
Okay, thank you. Professor Gladel, Dr. Suhaila asking, do you use T1 subcategorization in your TURBT?
So so in non-resections, in small samples, in that case, it's the cystectomy or a resection specimen, the staging is done by clinicians. So so the T1, I just use the T1 to kind of easier to explain, because I want to emphasize the importance for the clinician. So basically, we report as invasion to the lamina propria. We don't put the subcategory there. For the clinician, that will be a T1.
Okay.
They have to know that, they have to know that. So we don't use the word T1. We use staging though in our resection. That's the P category. When we put a PT1, PT2, that will be for the resection. This is for the biopsy or the TURBT. That's a clinical stage category that will be given by the clinician. But for convenience, I'm just using the T1 for lamina propria invasion. So for our report, just say it invasion into the lamina propria, and that's it. For them, it's a T1 disease.
Okay, yeah, thank you so much. It's very useful information. I hope that also the clinician can get it through. And I think, I think should be the last question. Can we see the glandular differentiation in low-grade carcinoma, urothelial carcinoma? Maybe.
So glandular differentiation, and so right now, if we look at the WHO, the number really of subtypes and differentiation, right, it's kind of proliferated. It basically just right now at least 14 different, like micropapillary, sarcoma, all of this, right? So it basically just proliferated. So glandular differentiation is one of them, right? And you also squamous differentiation, you have the malarial differentiation. Now it's settled, and there's a definitive answer for this. Once you have these subtypes or differentiation, it's automatically high grade. It's automatically high grade. And that's settled in the Basel ISO consensus, and now it's in the WHO, that if you have a subtypes of differentiation, that's becomes a high-grade disease. Now, when it turns to subtype or glandular differentiation, use that for only invasive urothelial carcinoma. Don't use this subtype labeling or variant labeling or differentiation labeling when you are dealing with a non-invasive tumor. It's only for the invasive tumor, and it's automatically high grade. Keep in mind that not only for the glandular differentiation, but there are other subtypes like that they look low grade. Like for example, the nested urothelial carcinoma. If you look at the morphology, they look like gland morphology. The tubular, the microcystic, there's are rare, but they look like they have this bland nuclei. And strictly speaking, if we follow the cytomorphology criteria that I discussed, they will be classified as low grade. But because they are subtype, like the glandular differentiation, that's automatically high grade. So don't call it as low grade with glandular differentiation. It should be high grade.
Okay, thank you so much, Professor Gradel. We are happy having you with all your knowledge and experience, but I think now the time is running for us and also for you. Thank you so much for being with us. This great support is highly appreciated. Thank you so much. And do you mind if we take a pictures with you before you leave us? Yeah, to all the members. Yeah, maybe I would like to also report that at the peak, we reached 169 participants for this webinar. And now, please open your camera. If you don't mind, we will take a pictures. Maybe the admin can help me. Then we take a pictures. Is it possible?
Yes.
Yeah, okay.
Yeah.
So please, all doctors, professor, and also the participants, could you please open your camera? And then you can start to take a picture. Now it's only the SEAUPS words. Do you see any or everyone is open
Yeah.
the camera? Yeah?
Yeah,
Okay,
I
then.
can see gallery. I will
Yeah,
start
okay.
taking the pictures.
Yes, please.
So for the first slide, 1, 2, 3. Okay, and for the next slide, 1, 2, 3. And the third slide, so there will be 7 slides.
Oh,
Okay, 1, 2, 3. Yeah. Fourth slides. 1, 2, 3. Okay, yeah. I think that's all for the pictures.
okay. Thank you so much. Thank you for your very clear presentation and lecture, Professor Gradel. We do hope that we can see you next in Bangkok and also maybe in our future webinar. And we are looking forward to collaborate with you with other project. And have a good morning, Professor Gladel. Thank you so much. Hopefully, we can see you later on.
Yeah, for sure.
And
Likewise. Yeah, thank you for the opportunity. It's a pleasure.
thank you so much. And please, if you will stay with us, we are really glad. But if you will continue with your activity there in the morning in Chicago, please, Professor Gladel, thank you and see you. And please let me introduce our second speaker that will share with us a great case. I would like to welcome Dr. Richard. Please, Dr. Richard, hello.
Hello, everyone. Good
Yeah.
evening. Good
Good
morning.
evening. Thank you, Dr. Richard, for coming with us to share a case. Yeah. Are you ready?
Yeah.
Yes. Thank you. Yeah, please, Dr. Richard, time is yours.
Okay. Can you see my slide?
Yes,
Mm.
it's clear.
Yeah, okay. Good evening, good morning, everyone. My name is Jung Pasumi. You can call
Oh.
me Richard.
Excuse me, Dr. Richard,
Ah.
sorry. This is not the slide
Okay.
presentation yet.
I will share again.
Yeah, please.
Okay, can you see the
Yes,
presentation slide?
great. Now it's work, please.
Okay. Good evening, good morning, everyone. My name is Jung Pasung Nguyen. You can call me Richard. I'm from the Department of Embryology, Histology, and Pathology of Medical School, University of Medicine and Pharmacy at Ho Chi Minh City in Vietnam. And today I'm very delighted to present an interesting case with the title, Our World is Small, Round, and Blue. Our patient is the 58 years old man with the hypertension. He also had the polycystic kidney disease, and he presented with 3 weeks after pilot cross hematuria. And in the CT image, he had the 9 centimeter bladder mass, invasive to the very vertical fast and invasive to the right ureter. And he also had the lymph node metastasis in the abdomen, and he underwent with the transurethral resection of bladder tumor because the bleeding during the resection, so the tumor cannot be completely resected. We have the multiple fragment here. In the histopathology, we can, from the low power field, we can see many fragment of tumor. In some area is dark, some area is light, and some area is hemorrhage. In the higher power field, we can see the tumor cell arranged in the solid sheet like the nested pattern with the interleaf vessel. In another area, we can see the rosette pattern here, and we also see the small to medium size cell with the scan cytoplasm and the nuclei around, and we can see the nuclei molding, and we cannot see the nucleoli. So with your with the histopathology feature here, what is your initial diagnosis? Can you show the one question? Okay. A may be polydifferentiated urothelial carcinoma. B may be lymphoma. C may be melanoma. D neuroendocrine carcinoma. E embryonal rhabdoid myosarcoma, and desmoplastic small round cell tumor. Okay, here we have 80% participants in about the neuroendocrine carcinoma. Next may be polydifferentiated urothelial carcinoma, and someone think about a lymphoma. We can, okay. In another slide, in the high power field, we can see clearly the tumor cell is small, less than 3 lymphocytes in diameter, with the high nuclei on the cytoplasm ratio, and on the for the nuclei we can see it had the sharp and purple chromatin pattern, and we can see the high mitotic activity and some atypical mitosis here. And from the histological feature here, we I think about the neuroendocrine carcinoma. Another area, I can see some basophilic round structure here. So what's your thinking about this structure? can it be vascular invasion, or it can be the artifact by the hematociliary portion, or maybe atypia phenomenon. Okay, we had the result here. Mostly participants think about the atypia phenomenon. Someone think about the vascular invasion, and someone think about the artifact. So for this structure is the atypia phenomenon. This phenomenon was described by Professor John G. Uropathology. So about the mechanism of this phenomenon is usually in the high-grade tumor with the tumor cell arranged in sheets or cluster, and tumor have the high nuclei on the cytoplasm ratio, and nuclei have it maybe have the atypical mitosis and necrosity. And because the neurosis of the tumor cell, some nuclei release the nucleic acid, and this nucleated material will deposits in the wall of the vessel. So on the S&E section, we can see it's the petrophilic material surrounding the vessel walls. So it's the atypia phenomenon. So next question is the atypia phenomenon specific to the small cell carcinoma. The result is 70% think no, someone think yes, and maybe 4 participants don't know. Okay. Smartly, atypia phenomenon was seen in the rabbits growing and degenerating tumor. Beside the small cell carcinoma, it can seen in the Burkitt lymphoma, medulloblastoma, or ependymoblastoma, or mantle cell carcinoma. And the atypia phenomenon can be seen in the area of neurosis, and it's another feature from our case. Beside the feature of small round blue cell pattern can seen in the neuroendocrine carcinoma, it can be seen in the another tumor in the bladder, in the urinary area like lymphoma, melanoma, embryonoblastoid myosarcoma, desmogletic small round cell tumor, or fully differentiated urothelial carcinoma. For lymphoma, it can have some feature to differentiate this. In the bladder, the Mon lymphoma is the most common primary lymphoma of bladder, and the tumor cell can positive for the CD45. It can positive for CD3 on CD20. And for the melanoma, the tumor cell can be in the epithelioid on window cell appearance, and it can positive to the melanocytic marker like S100, SOC10, SMB45, and melan-8. And in the neuroendocrine carcinoma, the tumor cell can arrange in the solid, native, and trabecular patterns, and the tumor cell can have the scan cytoplasm and the round nuclei, and the nuclei can have the sharp and purple chromatin, and it can positive to the neuroendocrine marker like bromogranin 8, synaptophysin CD56, and INSM1. For the embryonoblastoid sarcoma, is the most common tumor in kids and infants, and the tumor cell can be in the rhabdoid appearance, and it can positive to desmin, myogenin, and MyoD1. And desmoplastic small round cell tumor is comprised of the next or trabecular small round cell in the diffuse desmogletic tumor, and it's can positive to WT1 CD99, desmin, and vimentin. And finally, the fully differentiated urothelial carcinoma is either rare tumor of the bladder, and it can be in mostly in men from the 70 to 90 years old, and it's comprised of the mononuclear malignant epithelial cell with the multinucleated giant cell here. And in the immunohistochemistry, the mononuclear cell will be positive to CK or MA, and the multinucleated giant cell will be positive to CD68. Compared to our case, in the immunohistochemistry, the tumor cell is positive, diffuse and trans-positive to bromoranin A, weak, diffuse and positive to synaptophysin, and positive to CD56. Besides that, it's positive focally to the GATA3 and P63, and negative to the 34 beta E12, and it also had a high Ki67. So summarize of our histological findings, this tumor had the solid sheet-like netted rosette patterns. The tumor cell is small with a scan cytoplasm, and the chromatin is sharp and pepper nuclear motif, and it also have the high mitotic activity and a typical mitosis. We can see antibody phenomenon and neurosis, and it's positive to the neuroendocrine marker. So the final diagnosis for this case is a small cell neuroendocrine carcinoma. For the follow-up of patient after performing the transurethral resection of bladder tumor, the patient received the neoadjuvant chemotherapy, and he have the partial response. After 3 years of follow-up, the patient have the progressive disease with the metastasis to lung, to brain, and to the lymph node in the intra-abdominal area. Despite he received the radiation therapy or chemotherapy, and after that, the patient received the palliative care, and to now we're not sure about the patient is still alive or die, because we lost the follow-up. According to WHO classification of neuroendocrine in the urinary bladder cancer, is comprised of neuroendocrine tumor is well differentiated neuroendocrine tumor. This tumor have the feature of neuroendocrine tumor, and it have the mitosis and Ki67 index is low. Another neuroendocrine carcinoma is comprised of small cell neuroendocrine carcinoma. It had a small round blue cell less than 3 lymphocytes in diameter, and it frequently have the high mitosis and neurosis. For the large cell neuroendocrine carcinoma, it have the pleomorphism and prominent nucleoli. And for the mixed neuroendocrine neoplasm with the non-neuroendocrine neoplasm, it can be urothelial carcinoma, squamous cell carcinoma, and adenocarcinoma. Its component at least 30% of the tumor. Some information about the small cell neuroendocrine carcinoma in bladder. It occurs between the 5th and 8th decades of life, and predominant in male, and it's the gray case. It's the gray tumor in the bladder tumor. And smoking may be the cause of the this tumor in bladder, and the tumor cell can originate from the stem cell. And more than 90% of the bladder small cell neuroendocrine carcinoma lack RP1 expression. And the tumor is positive to the neuroendocrine marker, and around 50% this tumor positive to TTF1. So we cannot use the TTF1 to differentiate the metastasis small cell carcinoma from the lung. And this tumor can be positive with the epithelial marker, and it had a high K67. About the treatment, up to date, no treatment will show effectively for the small cell carcinoma in bladder. This can be combination between the surgery, chemotherapy, radiation therapy, immunotherapy, and targeted molecular therapy. But for each treatment modality, the 5-year survival for is different. Like for the surgery only, the 5-year survival is only 12%. And the therapy comprised of surgery and chemotherapy, the 5-year survival is 30%. And multimodal therapy combined of surgery, chemotherapy, and radiation is around 32%. About the prognosis of the small cell carcinoma in bladder, this is a poor prognosis tumor because more than 90% small cell carcinoma in the advanced state at the presentation, and this tumor is very aggressive and rapid progression. And this tumor usually may start to the brain, bone, lung, and liver, renal gland. And this is a study will collect data from the SEAR database from 2000 to 2020, and the total case is around 1,000 of the urinary bladder neuroendocrine carcinoma. And we can see the overall 5-year survival is very low, around 22%. And the count-specific survival for bone metastasis, brain metastasis, liver metastasis, and lung metastasis is very low, around from the 12 to the 24%. There are some take-home messages. Neuroendocrine tumor is very rare in the genital urinary symptoms, and neuroendocrine small cell carcinoma of the bladder is very aggressive, and the diagnosis usually at the advanced stages. And this tumor have the poor prognosis, and for the treatment, up to date is no treatment effectively for this tumor, so multimodal approach is highly suggested. Finally, I want to say my thanks to the CF for organizing this event, and thank you for Dr. Nick for supporting me. And our world is small, round, and blue, so we have to bow together to love each other, helping each other, collaboration, and stay connected across every ocean and border. Thank you for listening.
Thank you so much, Dr. Richard, for your case. This is a very interesting case, and I don't know how many of us has been experienced diagnosing this kind like rare tumor. I have a question. Maybe you can give enlightenment to me. The salt and pepper nuclei, can we observe it in the large cell neuroendocrine, or it's specific belong to the small cell only?
The salt and pepper Chromatin is, I think it can be observed in the neuroendocrine tumor, is including the small cell carcinoma, large cell carcinoma, or the well differentiated neuroendocrine tumor. But the large cell neuroendocrine carcinoma can be usually have the pleomorphism, and we can see the prominent nucleoli in the tumor cell. Yeah, it's not specific for the small cell carcinoma.
Yeah, okay. Because I think I've discussed it with my residents, I think this week, about that kind of the chromatin appearance. I do believe that in the neuroendocrine we can appreciate it through the well-differentiated neuroendocrine tumor until the large cell or even in the mix. I see some question, Dr. Richard. Would you please answer? In female patient, how to determine whether the neuroendocrine carcinoma originate from the bladder or actually an extension from the cervix? Yeah.
It's a great question. The same, I think I had the same answer from the like Dr. Gadel. We are not alone. We can determine by the clinical information of the patient. We can use another tool like image or the from the assistant from the clinicians can help me to determine whether it's originates is from the bladder or can be extend from the cervix. Yeah, this is my question. We can we can compile many information to make the final diagnosis. Those based on only the histopathology feature.
Yeah, I think the imaging also can help us enrich the information about the case. Yeah, Dr. Richard, do you agree? But any particular immunohistochemistry that can help us with this to differentiate? Oh yeah, this is from a female cervix, for example, and this is from bladder, let's say.
Actually, I don't have the experience to using the immunohistochemistry to differentiate it, but it can be because neuroendocrine carcinoma can express to the epithelial marker, and I'm not sure. Yeah.
Yeah, thank you. Yeah, maybe I don't know, maybe in the recent years there will come some new antibodies that can help us answer this question. Okay, there is a comment from Dr. Rowan Yolo to you, Dr. Richard, that he noticed in the presence of the hemorrhoid rosette in your initial H&E slide projection. Can this feature be confused with the azopardi phenomenon?
The hemorrhoid rosette is the rosette with the lumen in the center of the rosette. So this feature is not specific for the neuroendocrine carcinoma. It can appear in another tumor like medulloblastoma. So we in another tumor. So this cannot trace forward to the neuroendocrine carcinoma. And it cannot be confused to the atypia phenomenon because, as you see in the histopathology feature, it's quite different.
Yeah, I do agree. Yeah, though this case may be not our daily practice, but once you experience with this, maybe you will not forget it. Or you have to check to your book to ensure, okay, this is azopardi phenomenon and this is the other thing. Then I do hope that it will help to give or to decide for the case. Yeah. Some comments regarding the differentiation for the original location, whether this cervix or whether this from bladder. Also agree that maybe the P16 can help. Most of the cervical carcinoma is related to the HPV virus. Then maybe it can help. And also the INSM 1, Dr. So suggests we can use and aid that beside the standard panel for our immunohistochemistry.
I agree. Yes, because the panel of the neuroendocrine marker is depend on the department. From our department, we do not use the IMSM1. We usually use bromelain, synaptophysin, and CD56, and yeah, and I think it's enough for us. So it's the right idea if we integrate to the INSM1 to make the diagnosis.
Yeah, I do believe if we don't have limitation, then we can perform chromo, synapto, also INSM 1 and P16 with very cautious interpretation. And yeah, also the imaging will help us, right?
Yeah, if we have many tools, this will make our diagnosis will be easier.
Yeah, indeed. Thank you, Richard. I think there is no more question. Thank you so much for sharing with us tonight in our Southeast Asia region. Good luck with you in Ho Chi Minh City. And also highly appreciation. I do hope that in the future we can share another interesting case.
Thank you very much.
Thank you and see you. And to all the participants that still with us until the end of our webinar today, thank you so much. Your kind support is really heart-touching for us as a new society in Southeast Asia. I would like to inform you that we will have another webinar. We schedule it for January 2026. And also there will be an offline lecture from our president, Dr. Jeffrey So, during the IAP meeting in Thailand early November. So if you have an opportunity, you can meet us there in IAP Thailand in Bangkok the first week of November. You can check it from their website of the IAP Thailand. And please join our next webinar on January 2026. It's coming. And all the materials that we had today will be available on our website. Please take care of yourself. Thank you for your participation. Highly appreciated. Also for all the education team of the SEAUPS and the committee, the founders. Thank you so much for your help and support. Thank you from me from Indonesia. Have a good rest and have a nice weekend. I will close this webinar now. Thank you. See you.